Thank you for joining our October education series, where we will be hearing from our very own Dr. Lucinda Bateman. She's going to be giving us some tips and tools on communicating with your healthcare team and an effort to kind of overcome the barriers that exist. So go ahead, Dr. Bateman.
Thank you. I appreciate it. When I try to think of a topic to speak on at one of these meetings, it's usually weeks or months in advance, and I try to think of something that's a big problem that we need to deal with. But then that usually means when I go to write the talk, if it wasn't a big problem, we wouldn't need to talk about it. So what I want to talk about today is some of the many barriers that people face who have ME/CFS. Looks like I'm not advancing. Hold on just a sec. Got to get our slides advancing in just a moment.
Oh, really? Let's see.
Want me to just say next slide and have someone do it?
We had it set up. Yeah, we might have to.
So next slide, please, whoever can advance. You know, individuals with ME/CFS experience so many barriers to compassionate and informed care that it's really hard to know where to start. But I believe now is the time for us to push back on those barriers, and especially the ones based on ignorance, bias, and inaccurate information. We have enough barriers, actually, without those. Next slide, please. And I'm going to be referring to these two groups on both sides of the barrier. On the left side is going to be the person with ME/CFS, and I'm just going to lump comorbid conditions, whether it's fibromyalgia or dysautonomias or whatever. And I decided on an abbreviation of PME/CC. So if you see that in the slideshow, then you'll know I'm referring to that community. And on the other side are providers, primary care specialists, surgeons, other ancillary providers. And it seems like there are many barriers to getting the right kind of care that we need. Next slide, please. Not being believed is a huge barrier that can result in improper treatments, medical neglect, abandonment, and even malice. And it can have powerful emotional and mental health consequences. There's no reason that patients with ME/CFS or any of the associated comorbid conditions should be disbelieved. I tried to come up with 4 major categories of barriers so we could kind of address these barriers one by one. The first barrier is ignorance, and basically that means being uninformed. What feels like neglect and abandonment can often be just naive, innocent ignorance on the part of medical providers, and simply lack of exposure and knowledge. It can certainly be aggravated by the fact that this illness is a very difficult one to communicate about, and we lack objective tools. So that creates a barrier in and of itself. There are many types of financial constraints on both sides of the barriers. And then the fact that this is a disabling illness, and there are issues of immobility and all of the other things confounding when patients are severely ill and maybe even have a hard time going to the doctor. So we're going to take these one by one. We'll start with the next slide. First barrier, this is the barrier of ignorance. Uninformed providers. We're going to talk about providers first. They may have no understanding or limited understanding of the illnesses. They may have emerged from a system with little or no training in this area. They're also under negative pressure from higher authority to perform and not to deviate from the norms. We need top-down and bottom-up education. we must not only educate primary care providers, but we really need to educate specialists, because this is a multi-system illness complex, and each of the specialties is going to find this dissecting through the work they do. We need to bring specialists out of their narrow silos and have them talk to each other. And we need to develop forums and common language for interdisciplinary exchange between those groups. I just came from a conference last weekend, a dysautonomia conference, where cardiologists, neurologists, general surgeons, physiatrists came together to talk about POTS, postural orthostatic tachycardia, and it was a very invigorating discussion. But you could see across those disciplines sometimes a little different language, a little different understanding, a little different terminology. So that kind of crosstalk is very important. We need to inform our primary care providers. You know, correct identification of a complex multi-system illness is just not easy using the information and tools they have learned. They've learned reliance on short history, focused exam, labs, imaging, and none of those things fit in a complex chronic illness. We need to teach our primary providers how to ask about the major presenting symptoms of ME/CFS. And these kind of parallel the case definitions criteria, and especially the Institute of Medicine National Academy of Medicine criteria that were published in 2015. You know, our doctors need to learn how to communicate about this profound inability to function, both physically and cognitively. We have to be able to communicate about the negative consequences of activity, disordered sleep, cognitive impairment, orthostatic intolerance, widespread pain conditions, and then the nonspecific presentation of symptoms that seem like infection, immune symptoms, inflammatory symptoms. These are really difficult for doctors who've been trained in their systems to be able to integrate and to take into the clinic. We need to teach them especially about the ones that are going to distinguish this from other illnesses, such as the impaired function and the post-exertional malaise, the consequence of doing activity, and the orthostatic intolerance part of the illness, which may be very complicated and could actually have many causes in a differential. They need to know what to look for that distinguishes ME/CFS from other illnesses characterized by fatigue, pain, and bodily symptoms. And while if you're the patient with the illness that walks into the doctor, your illness is crystal clear to you, but it may be quite difficult for the doctor to weed through all the different things that can walk in the door and work their way down to the correct diagnosis. I really feel strongly that the Institute of Medicine clinical diagnostic criteria that outline the core symptoms, not all symptoms that are possible with the illness, but the symptoms that the majority of ME/CFS patients have in common, that distinguish patients clearly from healthy controls. And this is based on very good research. These criteria require all the core symptoms be present at least 50% of the time, and moderate to severe in nature. If these criteria are applied, it becomes much easier to weed through the symptoms and come to a more solid diagnosis. These are the things we need to teach our doctors. But even if they can identify patients with these common core criteria, we know these criteria still define a heterogeneous group. And that is what presents the challenge. Primary care physicians need help from specialists to continue investigation into these debilitating aspects of illness. But the initial screening is imperative. So we need to teach primary care providers to be able to do this initial screening, identify patients with these profound disabilities, and then partner with the appropriate specialists to understand the underpinnings and the physiology and the appropriate treatment, supportive care for these aspects of illness for ME/CFS. Is medical education improving? Well, yes, actually, there are a lot of changes coming to continuing medical education resources, and I want to talk a little bit about that today. Uh-oh. That's not working again. Next slide, please. So, how do physicians learn? Once they're trained as a medical student and as a resident, and that's very structured, but once they get out into practice, whether it's in private practice or in an academic center, physicians and other medical providers learn by attending scientific meetings, continuing medical education conferences, usually by subject matter, sometimes big conferences that cover many, many topics. If it's a specialty conference, then MECFS, has been excluded and doesn't fit in. If it's a general conference, sometimes there's so many topics that it's very difficult to, raise the MECFS and its associated conditions to a place where primary care or generalists can see how important it is and to distinguish it from all the other many, many things they have to know. Those kind of meetings are usually quite expensive, and they're often paid for by employers in large medical institutions. But if people are in private practice or struggling, sometimes going to those kind of conferences can become very pricey. They have to miss time at work and pay to go get their education and get their credits. There are many online educational resources I'll talk about in a minute, and there are some continuing medical education courses offered by local, state, and national medical societies and organizations. Why is this important? Because if we want to improve medical education, we need to know where to go to make those changes. Next slide. So I want to tell you some things that are pretty exciting and positive. Medscape, you may have heard of this before. This is owned by WebMD. Most people know about WebMD. And Medscape is a large website that provides free medical education and lots of information to medical providers. Medscape has been very supportive of moving forward and providing information, correct, more up-to-date information on MECFS, and I commend them for that. UpToDate is an example of a system of education marketed as an evidence-based clinical resource. It is written by thousands of physician authors, editors, and reviewers, and it's available on your phone and the internet. It's a medical reference for doctors, both in training and in practice, so they can look something up and learn and brush up on the details. This is pretty expensive. It's more than $500 a year in the U.S., and so this is considered a high-level resource. And I have to say that in the past, the material in there about MECFS was very outdated, but they've made efforts to bring some of the material up to date and learn the new science and at least present a more modern view of what we know about MECFS. And there are many others. So these are ways that those of us in the correct positions, wherever that might be, can start to target and get in and provide more up-to-date, more scientifically based information reflecting what we know now about MECFS. Next slide. So I want to tell you about an effort that I was pretty proud of, and I was proud of the people who initiated it. But some patient advocates from Pandora, an advocacy organization, worked with us and with the Michigan State Medical Society that has a nice website and provides continuing medical education programs that are free for providers. So providers can go to the website, listen to the talk, and go through, take a little test, and there are two very accessible continuing medical education programs. You don't have to be a doctor to get on there. You can go read it if you're interested. One is an update on making a diagnosis, and the other is really about how do we go about treating this illness when we don't have treatment guidelines. There are many ways to access it. You can find it on the Michigan State Medical Society website under the education and on-demand webinars, or you can come to the Bateman Horn Center area for medical providers, and there's a few resources for medical providers, including some other CME programs, and this is among them. Next. So what about specialty providers that are uninformed? This can be a major barrier to access to care. And my advice is to avoid specialists who rely on procedures alone and don't spend time with patients. Now, it depends on what your goal is. If you just need to get a colonoscopy so that you can rule out colon cancer or inflammatory bowel disease, just go get your colonoscopy with whoever can get you in quickly and do a good and safe job. If you want to consult with someone about the unusual gastrointestinal symptoms that occur in ME/CFS, you're going to need to find a specialist who maybe is in an academic center, is experienced seeing complex patients. I can tell you from interfacing with many specialists, they will recognize the illness in an ME/CFS patient. They might call it something else, but if you can be flexible with that, right, then you can access them and get their help for the symptoms. But if you don't go to kind of a higher level specialist who's got a lot of experience and is used to dealing with complex cases, it might be kind of an unsatisfying visit. And you'll go away without much help and feeling like there was a barrier to communication and not getting the kind of results that you hoped for. It's important to know that specialists are loath to label a diagnosis without objective support. And you just have to understand that. If they can't see a test or a lab test, it's harder. There's a lot of pressure on specialists to follow a scientific path and be able to provide objective data. So you need to be patient with that. When we're working to get better diagnostic tests. We need to bring specialists, again, out of their silos, and we need to develop common language between specialties so we know we're all talking about the same thing, and then we need to work toward providing the best objective data we can to specialists so they know how to proceed and they can get involved and come in and help us solve these problems. So let me give you some examples. Let's say there's really two phases when you develop a horrible chronic multisystem illness. One of them is knowing that you've had a good diagnostic workup to rule out other problems. And that's step one. Step two is, how do you find the help you need for these very technical problems that affect multiple systems in your body? And I've just made a list here. So these will be neurologists who have some expertise in autonomic nervous system diseases, neuroinflammatory conditions, small fiber neuropathies, the things that we're finding in the differential of patients who have this illness, cranial cervical instability, low spinal fluid pressure, post-concussive syndromes. Don't just go to an ordinary neurologist who's going to whip you through, do an MRI and an EMG and send you home, because that is not going to be very satisfying and we're not going to be able to make progress. Same with allergy immunology specialists. If you just go to someone who's just doing allergy shots over and over and scooting you in and scooting you out, that might be helpful for treating your allergies, but you need to find someone interested in dealing with kind of ill-defined presentations of immunodeficiency disorders, mast cell activation, and some of these frontline abnormalities that we think might be the underpinnings of these related illnesses. You should see a rheumatologist who isn't just going to do a panel of labs and feel your knuckles and send you out the door. You want to find one who may specialize in Sjogren's or seronegative rheumatoid arthritis, which just means the blood tests are all negative, Ehlers-Danlos syndrome and hypermobility disorders. If you go to a person who's a little bit outside the mainstream and willing to take on the hard questions, you're going to get the kind of consultation you need. That's removing barriers. So that's my point, is so that you don't feel like there's a barrier everywhere where you turn. Same with cardiologists. If you can't find a cardiologist, there's the cardiologists that just do an echo and put you on the treadmill and a Holter and they're done, one and done. That's the differential diagnosis. But if you can find a cardiologist that's interested and open, willing to look at autonomic nervous system. Your heart and your circulatory system are all run by the autonomic nerves and signals from the brainstem. And it's sort of this gray zone between cardiology and neurology where we think some of the problems are with this illness. And gastroenterologists who aren't just going to do a colonoscopy. They're interested. They look for celiac disease, look for subtle neuroinflammatory disorders and others of the GI tract. Okay, so we've talked about uninformed physicians, primary care, and specialty, and how you might approach the barriers. So, you know what? If you as a patient or your family and your caregivers are uninformed, then that's a barrier too, because you don't know how to access those people and you can't get through. It's overwhelming. I think I went too far ahead. You feel overwhelmed and traumatized when you get sick and you're not a doctor, although there are doctors who get sick and they have some advantages. You must learn to educate yourself gradually and broadly, relying on high-quality resources. Do your homework. Don't just grab at anything that comes by, but read broadly and learn as much as you can. You also need to find a primary care provider who will listen, communicate, and learn with you. If you can't go to your primary care provider and ask questions or bring up concerns, then you need to get another one. And those kind of providers they don't have to be a physician necessarily. They could be a nurse practitioner or a well-trained nurse practitioner or a physician assistant, especially those who have backup. And then seek highly qualified niche specialists, as we just talked about in the last couple of slides. Then, and this is pretty important, you've got to just hang loose with overlapping conditions and many illness definitions, and you need to learn about these comorbid conditions we've been discussing are subsets of illness that fall under the umbrella of ME/CFS. And it can be so confusing and you don't know who to listen to. So just kind of hang loose and realize that we're trying to overcome these silos. We're trying to bring together doctors with common language from all these different specialties. And you know, doctors use different language, different words and terminology. There are doctors who will never say the word fibromyalgia. They'll call it pain amplification syndrome, or they won't call it anything until they have an objective proof, like a small fiber neuropathy biopsy. Some people will never make a diagnosis of chronic fatigue syndrome. They call it post-infectious fatigue, post-viral fatigue. They might lump everything under Lyme disease. And, you know, it can be confusing, but just take a step back and try to look for the common themes and don't jump onto any one boat. What we need to do is pool our information and continue moving forward. Same with all these terms related to orthostatic intolerance, these kind of new insights about problems up at the top of your brainstem or where the skull meets your cervical spine. And some of the terms that are trying to convey, we think there's a bit of immune deficiency and there's evidence of inflammation. But sometimes all these different labels and terms can just feel not very satisfying. But I see it as a good start moving forward. And then we need to come together and share more common language among specialties. So how do you access, how do people with ME/CFS, how do people with ME, what did I say, PME/CC, people find legitimate information? Well, I want to tell you some promising things. Healthwise is a nonprofit company that develops health content and patient education for insurance companies, care management, hospitals, electronic health records, including WebMD. So this company develops the materials that get read by patients to teach them things, and it gets disseminated to all these different companies and places that you patients access. And I can tell you firsthand that this company has been doing a lot of work to update their pages on ME/CFS and related condition. They're coming to a much better satisfactory explanation of the illness that will help lead, if we can get it out to the public and to patients, if that's what the doctor's going to call up and hand to you as a resource off their electronic health record, that's huge, and I give them kudos for their work. So WebMD is one specific big online publisher. It's huge. And there's not just one, they have a network of websites and more unique visitors every month than any other leading private or governmental healthcare website. They recorded 179 million unique visitors per month and 3.6 billion page views per quarter in 2016. And they're getting some of their information from those resources that we've been talking about. So that's very exciting. Slow progress, but I want to say that it feels like nothing's getting done, but there actually is a lot behind the scenes, and it's taking a little while to trickle down. And the last place it gets is sometimes to our academic physicians or primary care doctors. When you get online, you need to go to websites of respected institutions. So if you can't get that generic kind of canned information, which we're trying to get more up to date, see if you can get on the website of an organization or an institution that does research in that area. For example, at Vanderbilt, they have an autonomic dysfunction center. They have an amazing website just for their autonomic dysfunction center with definitions and advice and references. It's great. I'll give you an example. In Michigan, the University of Michigan has a large program in fibromyalgia and a big research program, and they've been there a long time. When I went to the whole university and put in fibromyalgia, I got the canned information that probably, they purchase and put on their electronic health record, maybe that comes from HealthWise or one of these others. But when I knew to go to the research lab of the doctors who were studying and seeing patients in clinic, there were some really good resources for fibromyalgia. So trying to find out where the centers of the most advanced research and treatment can be helpful. You can go to trusted blogs and websites, organizations that you can trust that are on the leading edge. And that might be Bateman Horne Center or Solve MECFS or Health Rising. Health Rising, sorry, I'm up here. And there are many, but there are places very dedicated to bringing you leading edge information that you can trust. That's one way to get through barriers. I want to share with you, if you haven't heard already, that a clinician coalition, it's a coalition of MECFS specialists in the United States, has joined together. We've met a couple of times, bringing people who see patients with MECFS, trying to share our knowledge. And one of the things that we have done as a group is to create a 2-page document that can tell physicians, in a very concise way, these are the tests we do, these are the disorders we look for, and this is how we approach treatment. That is going to be available in many places. We have a link to it on our website, and we hope that this clinician coalition will continue to provide documents that patients can take advantage of for their own education, but you can also take this document into your doctor and say, this lists that sometimes people might have this problem. Do I have that? And if so, what do I need to do to work it up? All right. So that was the barrier of ignorance, and it's a big one, but that one is completely solvable. It is 100% possible to educate the medical profession and for any person who has the disease to dig in and get the information they need to go so that those two can come together. That is something that is fixable. The second big barrier is the nature of the illness and the lack of tools we have. This one's a little more difficult. So MECFS and comorbid conditions define a complex multi-system illness, maybe illnesses that are difficult to explain and difficult to discern. So difficult to explain is the quality of communication, and difficult to discern is how do you get the facts? How do you observe? How do you do an exam? How do you do medical evaluations? And the lack of frontline diagnostic tests means we must rely on clear explanations and communication. And this starts to rest back on you. I want to help provide tools for you to communicate clearly what's going on with you and do doctor speak so that you can break through that barrier that's going on the other side. Every aspect of this illness takes time to talk about and is difficult to quantitate. So I've got a few things here that we can use for tools. One tool is doctors always use what's called a review of systems. That's very typical. They do it when always with a new patient. Sometimes they pipe it in from their records on individual visits, which isn't quite fair. But what it does is goes through these various systems and asks you questions about the symptoms, usually just a few, to help the doctor be guided toward what the diagnosis might be. And I'm going to show you that what we've done at Bateman Horne Center is created a more expanded review of systems and inserted in the review of systems the type of questions that need to be asked to understand more about someone with ME/CFS or fibromyalgia. So we ask quite a few questions about fatigue, sleepiness, weakness, problems that develop after activity. And threaded through here are questions you may not realize, but when we ask someone about weight loss, doctors know that profound weight loss, that gets your attention, and there's a large chance there's an important medical problem underlying that. All of these things, doctors are trained to know how to look at them. But just saying these things are present isn't enough. So what we do in the clinic is we ask people to score their symptoms. So they put a 0 if they've never had the symptom, a 1 if it's mild or infrequent, 2 moderate in severity and frequency, and 3 severe or almost constant symptom. Why? Because the IOM criteria require that the symptoms be moderate, at least moderate, in severity and frequency. So I can look through that review of systems very easily and pick out the more important defining symptoms of this illness. It's a very good communication tool. And what I would suggest to patients, and I didn't go through and put the numbers on everyone, you can get a copy of this. You can make your own review of systems, and you can circle the things that are important, and you can score them for the physician so they know how important each of these things are. And here it is, sleep unscored, and here it is. You can see that when you score it, you communicate to the doctor very quickly how important that symptom it is and where it is they need to dig in to do further workup. It's a lot better than saying, "Doctor, I can't sleep," right? You see how important it is to develop clear information in a way that will get your doctor's attention. These are musculoskeletal symptoms. These are infection and allergy symptoms, heart and lung problems. If each one of these could be scored 0, 1, 2, or 3, and you hand that to your doctor, that is a very rapid and concise communication tool that will help break down barriers. And what's really important that often people don't ask are the things that are quite specific for ME/CFS, such as what happens when you exercise, what happens during exercise, what happens after, whether it's mental or physical, and how long do the repercussions last. If you can score those, that becomes very important communication. Same with neurologic symptoms, mental health symptoms, hormones, bladder and kidney, blood, skin, all of those. So you could theoretically, and maybe we can get this eventually on our website, have a page with the review systems, and you can score them all 1, 2, 3, 0, 1, 2, 3, and right away, boom, 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 I can go down and see what the most important presenting symptoms are. We can teach that to doctors. We can teach it to our primary care doctors. But even before that happens, don't let it be you that isn't the clear communicator. Take that into your medical providers, and if they're going to drop the ball, they will, but it gives them an opportunity to stand up and pick up the ball and take it forward. The next thing you have to communicate that doctors aren't trained very well to ask about and it's difficult is your activity tolerance. So we've developed this on our questionnaires, and when someone fills this out, I have immediately a clear idea of how debilitated they are by their disease. So we say, okay, think about your better days. We divide it into good days and bad days. So on your better days, about how many times, what portion of the month do you have better days? 1 week, 3 weeks? And then we ask about hours of upright activity. This is how many hours in 24 can you have your feet on the floor? So essentially it's all the time you're not sleeping or lying with your feet up or in a recliner. And this is the flip side. We put the hours of horizontal activity just to remind people that it should add up to 24. Then this is really helpful. We ask people specifically, what can you do on a good day? And what can you not do, even on a good day? That tells me the parameters of people's functional capacity. And if you just write down specific things, I can't sweep, I can't walk to the mailbox, whatever it is that you can do and can't do is a really clear communication of your functional capability. So same with the bad days, how many per month? On bad days, what are your hours of upright activity? And give specific examples of what you can still do on a bad day and what you for sure can't do on a bad day. That is a clear communication to your physicians about your activity tolerance. We also know that this might be a clue when the hours of activity are low, of upright activity, that people have a problem with orthostatic intolerance. And it also signals severe deconditioning in some cases. Now think about hours of upright activity. Normal healthy folks probably have their feet on the floor 14 to 17 hours. A lot of people don't ever put their feet up until they go back to bed. So I've noticed in our clinic that many types of people with chronic illness, especially for example, patients with fibromyalgia, they're more tired, they have to sit more, and their hours of upright activity may be lower, but they don't have to lie down to recover. They can sit down to recover. Patients with ME/CFS, it's stunning, but may have 0 to 6 or 7 hours of upright activity tolerance a day. That is a good, important communication to give a doctor. And unless you can quantitate this and really make it clear, that gives you, I'm hoping to give you tools to be able to communicate to primary care or whoever you are what your functional capacity is. So when you're talking about symptoms with doctors, you want to, and doctors learn this, but patients don't, so I'm telling you now, you should describe what it feels like to have a symptom. Don't try to say what you think is causing it right away. For example, I've had people say, I have inflammation in my neck. Well, you don't have inflammation, that's not a feeling, that's not a symptom. It's pain, it's tightness, it's heat, it's, whatever it is, you describe it with adjectives, and then you allow the doctor to create their own differential diagnosis. You don't want to insert something in their head. And inflammation means something different to doctors than it does to lay public. So you can get miscommunications. So describe what your symptoms feel like. When doctors learn to take a history, and it could be any symptom, but I'm using pain as an example, they're taught to ask the patient, describe the situations, describe the timing, frequency, duration, the severity, the nature, the description of the pain, and what makes it better and what makes it worse. When you go in, instead of just saying, doctor, I hurt, if you could go in and say those things, man, you're going to communicate like a doctor, and they're going to be much quicker to come to the right diagnosis. I also favor doing a pain diagram. Just fill it in. A picture is worth 1,000 words. Take that into the doctor if you're trying to communicate and you want to communicate clearly about pain. When you're communicating about symptoms, you can remove barriers by giving specific examples. And this is true not only in the doctor's office, but let's say in disability hearings and other places. Don't just say, I feel tired. Say, if I do this, then this happens, and give as many specific examples as possible. And you don't want to just state the worst case scenario, and you don't want to be an underreporter. You want to have a little breadth and be precise about when things are milder and things are worse and what those situations are. I also think, especially with this illness, it's really important to distinguish between these three things. One is feeling too sick to do something. Say, your doctor wants you to go on a walk and you just don't feel like you can muster the energy to go. The second would be developing symptoms while you're doing the activity, while you're doing the walk. So someone with coronary disease, probably feels well and can go on a walk, but they're going to develop chest pain while they're doing the walking. This is a little different concept than the consequence of doing something. So developing symptoms after you do the activity. And those are three very distinct things. And if you can separate those out when you give a history, that will help create more clear communication and remove barriers. Self-monitoring can become a very good tool. And I really encourage patients. Now, some doctors are like in a hurry or whatever. You know, if your doctors don't want to hear good, objective information from you, then you need to get a new doctor. So, blood pressure and heart rate at home. You know, learn instead of just say my heart was racing. Well, is it pounding hard or racing? Take some data. You know, see what your heart rate is. Because a doctor knows if it's 50, 100, 150, or 180, I know what those diagnoses are. It just falls immediately in different pots, but you may not know that as a layperson. Understand if your values are lying down, seated, standing, walking. So make some clear observations. Use a Fitbit or other things to track your steps per day or the problems with sleep. Bring photos. Do everything you can on your end to bring clear communication to make sure that the barriers are not on your part. I like people to use a Fitbit not to encourage them to take 10,000 steps a day, but to come back and say, you know what, I've been looking a long time, and if I stay below 3,000 steps a day, my symptoms are in much better control. On days I do 5,000 and I'm down the next day. So monitoring steps per day and being able to communicate that is important and more specific. Okay, we're going to leave that barrier. That was the barrier of an annoying illness, that the nature of it is difficult to communicate, and we have few tools. So barrier number 3 is financial. I would like to think that financial is never a barrier, but we all know it is. I can't even begin to discuss in this lecture the financial barriers that people with ME/CFS and comorbid conditions have. And I'm not going to try to tackle it. But of course, you know, insurance and disability and the support needed and everything, losing jobs and all of those things become very significant financial barriers. In many cases, this may be the most important barrier. But we don't have as much control over that. So I really want to focus on the things we have more control so that you can tackle and reduce and remove some of these barriers. So I want to talk about the financial barriers that are on the other side that your providers face, because if you understand the system, you can work within it better and make it work better for you. Medical providers are under tremendous pressure to be efficient and productive. They may have their pay docked, advancement blocked, or risk losing their job if they're not moving patients through and if they don't follow all the formal rules. They get pressure from insurance, colleagues, employers, quality assurance agencies, and they have a difficult situation. So you want to understand their scheduling constraints and try to work within the system. So these are some little hints of things that might help. Schedule more frequent appointments. That you should have no problem doing, just doing it in advance. They get paid, right? You're going to come in, you can come as many times as you want to address things. If you can make the appointments a little longer, if they will allow that, that's always helpful. We just need to let them know in advance that you're going to need a little longer time. And you want to prioritize and address specific aspects of your illness on different visits. Don't try to bring the whole giant list out and dump it on your doctor and have so many complaints they don't know where to begin, because they'll just short out and might have a hard time getting anything done. So try to prioritize the thing that's bothering you most and have frequent visits and let the provider become familiar with all the different things bothering you and start to put the pieces together about how they relate. Come to your appointments earlier on time. Be organized. Bring someone with you to be your eyes and ears and write stuff down and say things when you forget. Clearly state this is really important. Doctors, these are things that kind of annoy doctors, I can tell you, is make sure you state the things you want at the first of the visit. So it's really frustrating when I spend a bunch of time with people and toward the end of the time, and I've been liberal with the time, they say, oh, and what about my chest pain? Or, oh, I have forms for you to fill out, right? So be upfront about the things that you need to accomplish and let them divvy it out through the time and let you know if they have time to do it or if they need to do it in another visit. Prioritize the things you want to discuss, 2 or 3 or 4, and it never hurts to write lists or type things out before you come when you're more rested, you're not on the spot, you're not feeling a little worse. So all of these things, I think, can help physicians be more efficient and for you to be able to deliver your information in a more efficient manner so that it's more productive within their financial constraints. If you can bring your medication bottles or an accurate list of your medicines, that's really helpful. And I'm going to challenge you, everyone should know, you should know your medicines, you should know the names, you should know the milligrams. And you should be honest about how you're taking them. The more forthright you are, the more organized, the safer you'll be, and the better the care you'll get as you go from doctor to doctor. You should also keep an accurate list of all the medications you've tried and what happened when you tried them, so people don't reinvent the wheel over and over, giving you things that you didn't tolerate. Do home monitoring and bring the data in. It's hard to remember and be organized. I know people who do all the data collection and get there, and they're like, oh, I left it home. But be organized and bring it in. And this, we already talked about this one. Don't bring things up at the very end. And I'm just going to say, don't give your doctor homework. Don't give them a lot of things to do outside the visit, because they're busy all day long and their day ends and they need to go home. And if you give them a lot of things to do, it's likely not to get done. So make it easy for them. Try to figure out how you can, fill it out first and bring them extra copies and give them a stamped envelope or whatever is needed, and utilize staff. Everybody wants to help, but it becomes the system of doctors is so tight and so pressured that extra things actually make doctors not want to see patients with complex illness. So the better you can do that, the better care you'll get. Okay, we're near the end, and I can't spend too much time on barrier 4. I left this last because this is the real barrier that's going to be there. This isn't an artificial barrier of knowledge or of finances. This is a barrier of the nature of the horrible illness, ME/CFS, and its comorbidities. Moderate to severely ill people may find it difficult to travel to the office, difficult to find a ride, may not be able to drive, might be exhausted by the time they get there, and certainly might have consequences when they get home. Severely and very severely ill people may not be able to travel to the office. And if they do, there aren't mild consequences, but severe consequences. And this is a fact we need to address. We need to teach the medical system, we need to keep talking about, and we need to problem solve. We need to develop outreach and support for the severely ill. I don't know quite how to solve that yet. Our system isn't very good for that. But I did write down a few things that I thought might be good tips. Save up energy for the visit. Be rested. Be well hydrated. Don't get hypoglycemic. People like dropping down there because they didn't eat their lunch and getting dizzy. If you orthostatic, wear compression socks. Lie down in the car on the way. Use a wheelchair. If you're sensitive to light, wear sunglasses and ear protection. Ask them if you can lie down while you're waiting for your appointment if it's exhausting for you to do that. You can also communicate them, let them know you might need to rest in a quiet, dark room until the doctor comes in. If you're really severely ill, work with your doctor and get some IV fluids when you go to the visit, so that you'll feel tanked up when you're ready to go home. They can bill for it. And then be sure and rest after the visit. This starts to get a little more difficult, but for crashes or when you are really, if you live alone and you can't take care of yourself, it is possible to do home nursing services for short periods. You just need to know that there has to be a skilled nursing need and the patient must have homebound status. And if you have doctors who can work with you, there are ways to manage that. It's hard to do long term, but it's not hard to do short term. Just need to be a little bit creative about whether or not you need to give IV fluids and do vital signs and the things that warrant having a nurse in there. Some patients find a medical practitioner who will swing by their home. If you live in a small place or you can be near a clinic, see if you can arrange to have someone come by and see you. More and more, we're using telemedicine. And even if you're not at a far distance, if you're too sick to come into the doctor, work with a doctor who will get on a HIPAA-compliant platform and talk to you and see you and interact with you. More and more insurances are paying for this. It is tricky across state lines because licensing of physicians happens state by state. So it's really no problem at all within a state and starts to get a little trickier across state lines. And have family members or friends help you gather the information and do whatever's needed to help communicate and remove those barriers. But don't be invisible. Make yourself seen. What happens with severely ill and the very severely ill is they disappear. And we need to not disappear. We need to keep squeaking until everybody gets their needs met, and especially till we learn more about the situations. So that in summary, there are many barriers to care, but if you tease them apart, many of these barriers are surmountable. We can remove these barriers. There are things you can do now. There are things we're going to have to work on. But be strong and wear your wild socks. Thank you very much.
Cindy, can you say something about the importance of early diagnosis?
So the question is, what is the importance of early diagnosis? I feel pretty strongly that your prognosis is tightly hinged to early diagnosis. Not just early diagnosis, but early intervention and care. It doesn't have to be a magic bullet care. But, for example, if someone has a severe orthostatic intolerance syndrome, and believe me, we've been seeing a lot of new patients in the last year whose illness onset is within a 3-year window. And it's pretty common for them to have orthostatic intolerance that's completely unnoticed by everyone. Well, if you go around with poor poor circulation and not getting enough blood to your brain and to your tissues when you're up and around, that can probably start to cause permanent damage and problems down the road. We don't know for sure, but I do think it's important to get appropriate diagnosis as soon as possible. And even if you don't know everything about the diagnosis, just start doing supportive care. And so all that hinges on education and and access. Any other questions?
I have a question.
Mm-hmm.
I often get into my doctor's appointment and there's a million things I want to say or ask. Even if I write down a little list, sometimes I forget what was said. Is it awkward or inappropriate to use like the voice recording on my phone so I can go back and reference it later?
So the question is it okay to record the visit so that you can remember what was said? That's really dependent on individual providers. I'm really liberal and I don't care, but when someone sticks their microphone under me, I'm like, rah, rah, right? So it really depends on the person. That's another reason to bring someone with you, and you can't always do that. Take notes, bring your thing and take notes, and ask the doctor to write down the instructions. I try to write down the instructions every visit and give it to the patient. I'm a pretty fast typer, so I can do that. But I think communication is hard enough as it is, so as many tools as you can use is a good idea.
Thank you.
Any other questions? Are there any questions online? Go ahead, Suzanne.
There's so much information that we have to be able to gather ourselves in order to present to the physician effectively or to the provider effectively. And you know, there is now the means to be able to use technology, to use apps, to organize yourself and your information effectively so that you can essentially present it in a short visit, and it is, you know, nice and organized, and
Mhm.
the physician gets it
Right.
right away. Anyway, that's just kind of a statement. It's just like, because when my mom was sick and trying to piece together all the information that she had kind of collected throughout her life, it was impossible. It was
Right.
impossible to put together that kind of integrated picture for her providers at the time when, you know, it was really important to have all that data
Right.
there.
No, I get it. You know, we live in an explosion of information. The histories are complex, but that's all the more reason to just develop a pattern of being organized
Yeah.
and keeping track of things, and you know, the tests that have been done and the timing and where, because the longer the list gets, you know, the more important, the harder it is to remember.
Yep.
Now, some things aren't that relevant, honestly. We like to know them, but by the time 10 years have gone by, maybe it's not that relevant, except to know that it happened. We don't have to know all the details. But, and it'd be nice, you know, when you're ill and overwhelmed and feeling horrible, that you could just, people could just bring you in and take care of you. But in the absence, the nature of this, the barriers to this disease, make it so that it doesn't happen, right? So if we can figure out until we have better systems, I mean, I'm assuming that down the road we'll have diagnostic tests, we'll have imaging, we'll have the things that other diseases have, at least, you know, it will gradually come. But until then, you know, we've got to keep our doctors on their toes by providing them a smorgasbord of information and making it so they can't turn around, you know, turn away and just simplify the situation.
I loved your customized review of systems. That is just so powerful, and to be able to almost organize your information based on that.
Mhm.
When
patients- So when patients fill it out in that little bit longer modified review systems, but very specific for the thing we're looking for, I pretty much understand their illness before I see them, right? When I look at that and their activity level, most of my talking is to get to know them better, because so much powerful information comes across in those. So it may just seem like a lot of work for you, but it is how doctors think, to have that information. And if you want them to think for you, then you need to prime the pump with the information. I remember when I was a resident, I was moonlighting at FHP, which was one of the first HMOs in Utah. And I was working nights, and this woman came in, and she was just exasperated. She was probably about 30 years old. And she said, I've been here time after time after time, and no one knows what's wrong with me. Here are my symptoms. And there was this long list of her symptoms, and I looked at it, and I went, you have Cushing's disease, right? Because it all came together for me, because I didn't see her in these little bits and pieces of all those appointments. She was able to communicate immediately to me. She didn't even know she was, right? But because I knew the presentation of Cushing's, and I wasn't that far from my training, I was still a resident, just jumped off the page at me, and I was able to make a diagnosis that nobody else had made. So that's the beauty of information. You have to trust. And what I tried to put in the talk is, how do physicians process information? How do they want to hear it? How are they trained to hear it? And if you can sort of do it in that way, you're going to just see their little ears perk up, and they're going to be more excited to hear what's going on with you. Okay, well, we can't remove the barriers all at once, but we can certainly chip away at them. So good luck with that. Thanks.
Thank you, Dr. Bateman. Thank you all for joining. And just as a little reminder, this video is being edited and will be uploaded to our Bateman Horn website in a couple of days, and will also be able to be found via our YouTube playlist. We hope to see you all at the November 6th session, where we will hear from an MECFS patient and advocate, Linda Milne, as she speaks to a set of panelists about living a life of quality when living with a chronic illness. We hope to see you there.